So let's summarize what is relevant. The aorta is visible with transthoracic echo, but TE is better. We can also see the descending aorta, and don't forget about the aortic arch using the suprasternal approach. We can measure the aorta at the following points to fully describe the entire morphology: the aortic annulus, the sinus of Valsalva, the sinotubular junction, the ascending aorta, the aortic arch, and, if we can visualize it, the descending aorta, at least the cranial portions. The aortic size increases with age. For the development of an aneurysm, remember the rule of Laplace. Important is the wall thickness of the aorta, the size of the aorta, and the blood pressure. There is a very close link between the development of aneurysms, atheroma, aortic syndromes, and weakness of the wall caused by connective tissue disorders. Other inherited disease entities which predispose to the development of aneurysms and dissection include the Marfan syndrome, other forms of connective tissue disorders such as the Ehlers-Danlos syndrome, and bicuspid valves. Especially bicuspid valves also have a pathology of the aorta which tends to cause further progression of the aortic diameter even after operation, for example, of the aortic valve. We can classify dissection according to the Stanford classification. A would be an aneurysm of the ascending aorta, and B of the descending aorta. Patients with aortic syndromes are also at very high risk for aortic rupture. They have a similar prognosis as aortic dissection. We can describe penetrating ulcers, intramural hematoma, and localized dissection, which can lead to localized perforation of the aorta. When assessing aortic pathologies, look for bicuspid valves, aortic regurgitation, especially in annular dilatation of the aortic root, for plaque, which are also visible, especially from a parasternal long axis approach. Don't forget to measure the diameters, and if you suspect dissection, look for an intima flap, a true lumen, and a false lumen, which can be partially thrombosed. The indication for operation in aortic aneurysms is, for the ascending aorta, 55 millimeters. Unless the patient has Marfan syndrome, then you should operate earlier at a diameter of 45 millimeters. And for the descending aorta, somewhere between 60 and 70 millimeters. Don't forget to also look at the comorbidity and also at the progression of aortic size. Coarctation is characterized by upper extremity hypertension. Therefore, we see patients with hypertension referred to echocardiography who possibly can have coarctation. Use a suprasternal view to visualize the coarctation. Especially look at color Doppler to visualize the flow turbulences. And use continuous wave Doppler to quantify the degree of obstruction.